The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. My name is Ann Potempa, and welcome to our series of webinars provided by the Alaska Division of Public Health, Section of Chronic Disease Prevention and Health Promotion. This webinar series was created to talk about our projects and explore how we can work together. There are a few housekeeping items to go over before we are starting. If you're listening by phone, please keep it on mute. Please do not put this call on hold. If you receive a call, please hang up and call back in. The webinar is planned for 30 minutes, a 20-minute presentation followed by 10 minutes of questions and answers. A recording of today's webinar will be sent to all participants, and the slides will be available online soon. Next slide, please. Audio for this webinar will come through either your computer or a telephone, depending on how you signed in. Please hold questions until the end unless you have a technical difficulty hearing or seeing the webinar. To ask any type of question, you can raise your hand by clicking the hand button. You can also type in your question in the control panel. We'll be monitoring the question box throughout the webinar, but we'll answer most questions at the end. I'd like to welcome Andrea Fanati to start our webinar today. Thank you, Andrea.
Good afternoon. Today, our team is going to tell you about analysis we've just completed that touches on Alaska adults' beliefs about chronic conditions, including their understanding of the links between chronic conditions and risk of severe COVID-19 outcomes. I'm Andrea Fanati, and I'm the Deputy Section Chief and Surveillance and Evaluation Lead for the Section of Chronic Disease Prevention and Health Promotion. I'll start things off and then hand over to my colleague Ann Potempa in a little bit. So to cut to the chase, the three big takeaways for you are Alaska adults with chronic conditions linked to severe COVID-19 outcomes hold beliefs about health that may make it harder for them to take the preventive steps needed to improve their health. Social determinants of health, such as education and poverty, are linked to beliefs about taking steps to prevent and manage chronic conditions. And these beliefs, attitudes, and behaviors may be improved by using a social marketing campaign that reaches Alaskans who can benefit the most. Here's just an overview. I'm going to touch on some background and really high-level methods, then spend most of the time walking through the results and wrapping up with conclusions, and then passing it over to Ann to hear about next steps for social marketing. Chronic diseases, those that go on for a long time and often don't go away completely, are among the most common and costly of all health problems. Examples of diseases people live with for long periods, possibly a lifetime, are obesity, heart disease, stroke, cancer, diabetes, asthma, arthritis, and lung disease. Now, it's pretty well known that there are steps individuals can take to reduce the chance that they will get a chronic disease or to improve their health if they do have one. These include eating well, being active, avoiding tobacco use. The data show that although these steps are well known, many adults are not putting them into practice. One study in Alaska showed that only 15% of adults engaged in all four of the following healthy habits: avoiding smoking, limiting sugary drinks, being physically active, and maintaining a healthy weight. So what kinds of things make it easier for us to take these steps, and what kinds of things make it harder to do so? First, it's important to note that engaging in these steps that we know will keep us healthier longer, eating well, going to the doctor to get screened, are not simply a matter of individual choices. We're learning more all the time about how factors such as zip code, poverty, racism, and historical trauma, for example, can have a large role in limiting the actions available to us. But we also know from quite a bit of research that beliefs we have about ourselves and health outcomes can make it more or less likely that we'll take a certain preventive step, such as getting more physical activity. Several theories of health beliefs suggest that we are more likely to engage in a health behavior or stop engaging in an unhealthy one, the larger the stakes. That is, the greater the harms we think we will face by not taking that healthy step or by taking an unhealthy one. So how might COVID-19 factor into all of this? Several chronic conditions and their risk factors are associated with increased chances of severe outcomes from COVID-19, including death. Things such as history of smoking, having obesity, and also a number of chronic diseases, including diabetes, cancer, diseases of the heart and lungs. People with these conditions are more likely to end up hospitalized or even die should they become infected with COVID-19. So doing things like eating well and being physically active not only reduce the chances that you will get a chronic disease, but also reduce your chances of being hospitalized or dying from COVID-19. We wondered if knowledge of this fact might be extra motivation for taking preventive steps, such as eating a healthy diet, being active, avoiding tobacco use, and managing any existing chronic conditions. So with this study, we sought to assess Alaska adults' baseline understanding of the links between having chronic conditions or their risk factors and chances of severe COVID-19 outcomes, identify regional and demographic inequities in understanding this link, as well as in fatalism and self-efficacy to take needed steps, and ultimately use what we learned to inform a social marketing campaign with a goal of increasing preventive behaviors among Alaska adults. In June of 2021, we conducted a random digit dial text to online survey of adult Alaskans. This means we were able to have a randomly selected set of Alaska adults given an opportunity to participate in an online survey. We obtained responses from a little over 2,000 Alaskans ages 18 and older from across the state, relatively proportionate to the regions of the state. Respondents were asked about their history of the chronic conditions and behaviors that have been linked to severe COVID-19 outcomes. So smoking, obesity, kidney disease, heart disease, stroke, diabetes, cancer, and lung disease. We also asked questions about their understanding about the links between these chronic conditions and COVID-19 outcomes. A few questions got at whether they had a fatalistic view about chronic conditions, that is, they were just inevitable. A set of questions asked if there were steps one could take to prevent chronic conditions and if they were in fact taking those steps. Other questions asked about their confidence they could take preventive steps and how motivated they were to achieve good health. Finally, we asked about whether they had received healthcare provider advice on taking preventive steps in the past 12 months. And we, of course, included a number of demographics and region of residents so we could identify health inequities. Because characteristics of survey participants were different from the true state population, survey data were weighted to better represent Alaska's population. Statistical weighting incorporated age, gender, race, ethnicity, education, marital status, and whether participants lived in the Anchorage region. We first looked at overall frequencies of every variable and collapsed response categories as needed. We looked at bivariate associations between the demographics and each of the health belief questions. Finally, we ran logistic regression models with all the demographics included, so we could look at the independent association of each with each health belief. So now I'll walk through our findings. It was good to see that the online survey replicated an earlier analysis of Berthas data from 2016 through 2018. Again, we saw that 2 in 3 Alaska adults had at least one of the assessed chronic conditions or related behaviors that had previously been established to be linked to poor COVID-19 outcomes. In the blue box on the left, you can see the percent that have each of those chronic conditions. They add up to more than 67%, as some have more than one. The bar chart shows subgroups of Alaska adults for whom it was more likely that they had one or more of these, specifically those with less than a college education, those older than 45 years of age, and American Indian Alaska Native people. Now I'll walk through what we found out about each of the health belief questions we asked, highlighting any significant health inequities. In the interest of time, I'm cutting right to the results from the logistic regressions, where we simultaneously adjusted each model for having had one or more of the chronic conditions linked to COVID outcomes, region of residence, age, sex, race, education, and poverty level, where poverty is defined as the adults who have the combination of household income and number of household members. That puts them at less than 185% of the federal poverty guideline. Each table shows the adjusted odds ratios and 95% confidence limits and only displays a significant predictor. So all those covariates I mentioned are in each model, but really to keep it clear, these tables only show the significant ones. This first question was to see if people understood the link between chronic conditions and severe illness from COVID-19. The question asked there in bold, was it true or false that having one of the listed chronic conditions or related behaviors, we had provided survey participants a list, Does that increase a person's chance of severe illness from COVID-19 should they get infected? Overall, 70% of adults agreed that this was a true statement. Controlling for all other variables, those who themselves had a chronic condition, live in the Mat-Su, or are in poverty were less likely to say that this was a true statement. Women and those with more than some high school were more likely to say it was true. And note that college grads were 7 times more likely than those with less than high school education to understand the link between chronic conditions and severe illness from COVID. Very similar question asked about the link between chronic conditions and death from COVID-19. Overall, 65% of adults agreed that this was true. Those who had a chronic condition and those who live in the northern region were less likely to think this was true. Again, we see that those who had attained more education were more likely to agree with this statement. Rather than looking at their understanding of the link between chronic conditions and COVID in general, this question looked to see how concerned they were personally about their own risk of severe COVID outcomes due to a chronic condition or related risk factor. Overall, slightly less than half of adults were either somewhat or extremely concerned about their own personal risk. Significantly less concerned were those who lived in the Gulf Coast, interior, or Mat-Su regions of the state, and those less than 65 years of age. Significantly more concerned were, not surprisingly, those who had a chronic condition, women, and Asian people. Overall, 35% of adults agreed with the somewhat fatalistic view that if a person is meant to get a chronic condition, they will get it no matter what they do. Those with a chronic condition already, Black and Pacific Islander people, and those in poverty were more likely to have this kind of view. College graduates were less likely to have it. The vast majority, 93% of adults, agree that there are steps they can take to prevent getting a chronic condition as they age. College grads are significantly more likely to agree with this statement, whereas Black and Pacific Islander people and those in poverty were less likely to agree. Similarly, most adults are saying that, in fact, they are taking steps to achieve good health. Those more likely to say they are taking steps are women and college graduates. Those less likely are those who already have a chronic condition, those under 65 years of age, and those in poverty. Now, note that this is people's self-report of the steps they are taking, which they did not identify. And they also may be the right kind of steps and may or may not be the right amount needed to actually prevent a chronic condition. 9 out of 10 Alaska adults are at least somewhat motivated to achieve good health. Women, college grads, and those living in the northern region are more motivated than their peers. Those with a chronic condition already are less motivated. 85% of adults are at least somewhat confident that they can take the steps they need to prevent or manage a chronic condition. Those living in the northern region and those with higher levels of education were more likely to feel confident. Those with a chronic condition and those in poverty were less likely to be confident. And finally, just over half of those Alaska adults who saw a healthcare provider in the past 12 months said that the provider gave them advice on how to prevent or manage a chronic condition. Those with a chronic condition were more likely to have received this advice, and those living in the Southwest region and those under 65 were less likely. So, in summary, Alaska adults who have one or more of the chronic conditions linked to severe COVID-19 outcomes are less likely to have the kinds of health beliefs, such as higher levels of self-efficacy and less fatalism, that are often connected with positive behavior change, and are also less likely to understand the connection that exists between those conditions and risk of severe COVID-19 outcomes. Adding to what we already know about the links between these conditions and severe COVID-19 outcomes, a recent EPI bulletin put out by our section of epidemiology identified the underlying medical conditions of Alaska COVID-19 deaths from January 2020 through September 2021. From that report, we know that these chronic conditions here in this chart are quite commonly underlying conditions for COVID-19 deaths. It is concerning that the very Alaskans at most risk of severe COVID-19 complications may have a set of beliefs that makes it all the more challenging for them to protect their health. We saw a number of demographic and regional disparities in health beliefs related to chronic conditions and specifically the link to COVID-19 outcomes. but the most consistent health inequities across all the measures were related to education and poverty. Holding all other factors constant, Alaska adults with lower levels of education and those who were below the 185th percentile of the federal poverty guideline were less likely to believe that the list of chronic conditions we shared were linked to more severe COVID-19 outcomes. They also had more fatalistic views about the chances of getting a chronic condition and were also less confident in their ability to prevent or manage a chronic condition. And finally, were less likely to be taking any preventive steps themselves. The bottom line is that any prevention effort focused on chronic disease, whether a program, policy, or educational campaign that ignores these social determinants of health, will likely only make existing health inequities larger. As Dr. Castrucci of the De Beaumont Foundation shared at the Public Health Summit last week, when any of us cannot achieve our best health, we all suffer. Now I'm going to hand things over to Ann Potempa. Ann?
Thank you, Andrea. I'll have you drive my slides for you, but let's stick on this one for a minute. My name again is Ann Potempa. I'm a public health communications specialist, and I oversee a communications focused team within our section of chronic disease prevention and health promotion. We're in the early stages right now of following the social marketing process to build a new public education campaign that's informed by the evaluation Andrea just shared, with the goal of preventing and managing chronic diseases. We think this is a worthwhile next step since most Alaska adults have at least one of these chronic diseases. I want to take a minute to explain what social marketing is and what it isn't. Social marketing is not the same thing as social media. Social marketing means following a process that uses research methods to both inform and to evaluate communication campaigns that are designed to positively change knowledge and ultimately health behaviors. It's true that social marketing campaigns can use social media like Facebook or Instagram to reach an audience. But social media is just one small part of a larger evidence-based process to improve knowledge and behaviors among an audience. Social marketing is also most successful as a public health strategy when it's integrated into the programs it supports. As some background, we have decades of experience within this section using social marketing within our tobacco prevention program, using campaigns to increase the use of the tobacco quit line, as well as supporting the program's efforts to reduce smoking among Alaska adults. We are running a 10-year-old social marketing campaign called Play Every Day to support Alaska children to grow up at a healthy weight. And we've seen statistically significant behavior changes related to kids, serving kids fewer sugary drinks and increasing the serving of water during the years in which those campaign messages were running. We propose following the same type of social marketing process to create, run, and evaluate a campaign to prevent and manage chronic conditions that affect most Alaskans. Here are just some of the next steps that we're looking at right now, which is determining our priority audiences and our campaign goals. Completing a set of focus groups to better understand our priority audience in terms of their knowledge, barriers to behaviors, and motivators for behavior change. Then we'll follow up by testing some messages and developing an evaluation plan for the campaign. Next slide, please, Andrea. We're going to use the 2021 baseline survey that Andrea just shared the results from, as well as the upcoming 2022 focus group findings to develop and create a campaign. Likely elements could include, depending on the audience, campaign websites, video and audio messages, online and social media posts, and then any other communication channels that are a good fit for the audience. And that could be print, outreach through healthcare providers, and other methods. Next slide, please. Then we're going to run the campaign. We'll air and share the created materials through communications that reach this audience. We will strive to follow CDC best practices for reaching our audience with enough frequency to increase the chances of improving their knowledge and changing behaviors. And we'll strive for a sustained campaign that surrounds this audience with messages on their preferred multiple communication channels. Next slide, please. And then we'll evaluate that campaign, and that can look all kinds of ways. A basic evaluation looks mainly at, did the campaign reach the intended audience? Did the audience see and hear the messages? More advanced evaluation looks at things like, did the messages improve knowledge and behaviors and prevent chronic conditions? Did they improve knowledge of programs available to prevent and manage these conditions? And then the ultimate form of evaluation goes much deeper than that. Did the messages improve behaviors related to the campaign goals? Did more members of the audience make a behavior change while the messages were running? And did more members, for example, of the audience sign up for free and low-cost programs while the messages were running, if that was the campaign goal? Next slide, please. So thank you to Andrea for sharing the data today, and thank you for listening to us about where we plan to take this. And that ends our presentation today, and we have plenty of time on the clock here to answer some questions. Feel free to type them into the question box, and we'll watch for those as those come in. And while we're waiting, I just will remind you that this webinar has been recorded. It will be shared with all of those who have registered as well as attended today, and we will be posting those online shortly. There is a question from Lauren that says, do you plan to continue with more surveys or research to inform the new campaign? And what questions are you interested in next? Great question, Lauren. I'll start with saying I ended the talk by talking about what we're moving to next, and we're moving there quickly, which is a set of focus groups. We're still determining our priority audiences and our campaign goals, but this spring we plan to do 2 series of focus groups to better understand the knowledge, attitudes, and behaviors of this group, and then come back, create some messages to test, and do another set of focus groups for that. So that will definitely be on the front end of informing the campaign. Andrea, do you want to talk about survey potential?
Yeah, it's certainly, as you heard Anne talk about, the process of doing social marketing really leans heavily on research. And we did this first survey, intending it as a baseline. We probably won't ask the exact same questions. Again, as Anne said, a lot of that will get directed by the qualitative research that we do to determine who the priority audience is and what direction we're going to go. But absolutely, it's something that we plan on continuing so that we can look at the changes, not just in attitudes and beliefs, but also intentions and behaviors.
Thank you, Jennifer, for the kind comments. I appreciate it.
We have another question. It is, are you planning to use trusted individuals from various communities to promote messaging and acceptance within the communities?
That is a great question. And that is a primary strategy used for communication, is to use trusted messengers. So that will definitely be figured out as we determine who the priority audience is, and then who they say are their trusted messengers. That's often a common questioning line that we incorporate into our focus groups and or surveys when we are further exploring how to develop the campaign. Andrea, do you have anything to add to that?
I think that covered it.
We have another question comment. I saw a great program called movinghealthcareupstream.org, a national program to teach all age groups to the betterment of their health. I was wondering if a curriculum for schools would work as a part of a health class.
Andrea, are you familiar with this program?
Sorry, I'm not.
I'm not, but I'm definitely going to look this one up. Again, I think incorporating something like curriculum into schools will really depend on who the primary audience is when we determine this campaign. That could work for some audiences and perhaps not be the right fit for a different audience, but that's definitely worth looking into. And I'm actually copying this web address down right now so I can look up that program later. Thank you for that.
Okay. Seems like communication and building trust, not only in the science, but in the deliverer of the scientific information, is critical. Reaching the kids in school seems to be one of the ways of getting the message out, but real communication with those most at risk would seem to be a complementary track. How do you propose to do this?
Andrea, want me to take that, or you want to take that one?
Well, you can take a stab at it.
You're right. It's a huge challenge to figure that out. And it all just comes really to listening to your audience. I think one of the things that I'm most proud about of our social marketing campaigns in our section, the tobacco prevention efforts, the Play Every Day efforts, and this one, is that we really put a lot of primacy on having the audience be part of the process. So we have focus groups that have anywhere from 6 to 12 people on it, depending on how we're doing them. And they are all the very people that we are trying to communicate with in our materials. And we spend a lot of time on that at the front end. And we've learned so much helpful information from that. And that's where you can try to better understand some of these hurdles that they're facing in terms of how to reach them, other information they may be getting that might be counter to what we're talking about, and how to address that. So that's really why some of these kind of social marketing campaigns take some time on the front end to invest in really understanding the audience. Andrea? You might be frozen, Andrea. Hopefully I answered that one. Okay. Any other questions that have come up?
I don't see any more at this time.
Great.
Oh, actually, we just had one come in. It's from Julie Bates. She says, can you speak on how that gets set up in brush or smaller communities throughout the state for multiple focus groups?
Prior to the pandemic, we were able to do focus groups in person. And so I can think of a number of examples where we have actually flown out to, or used whatever transportation we needed to do to get to rural communities to actually host the focus group on site, which is ideal. The last couple of years, for safety concerns, we have moved our focus group facilitation to an online platform, typically Zoom. And that's what we're going to be doing for these focus groups. We're going to continue to do that, which helps on some ends. It removes the hurdle of travel and the difficulty for that part of the facilitation of focus groups. But then it introduces this new angle of needing to make sure the technology works and it can still feel sort of like a conversation, which is really what a benefit of a focus group does, is allows people to learn from each other and share among each other. So yeah, we will be using an online format to facilitate these. Thanks for the question.
Then I missed one earlier. It's from Lauren, and it's people responding with fatalistic attitudes and or lower self-efficacy in being able to take steps to prevent a chronic disease might be realistically responding to systemic racism or challenges of living in poverty. What solutions beyond marketing campaign can address those root causes in different responses?
That is really a great question, Lauren, and it's a question that Andrea has been spending a lot of time with. And Andrea, unfortunately, just lost power on her computer and has unfortunately had to leave the webinar. But that is definitely something we are going to be exploring further, since that came up as an issue of that showed differences among audiences within our survey. That is something we're going to be continuing to explore in our focus groups. And hopefully we can get a better answer for you as we move forward. We are hitting our end of the webinar here. I wanted to thank everybody again for coming. We have recorded this. This will be shared with you shortly, the slide deck as well as the recording. And please look for announcements for upcoming webinars. And thank you so much for your time. I really appreciate it.